So, hello everyone. Am I audible so that we can start the session? So, let me just check. Am I audible? So, let's discuss. Okay. Okay. So, I'm going to discuss the question being asked in the MDS examination of the dental question. So, NEET PG MDS Recall 2024, the subject anatomy. So, one by one, we can discuss the question. So, let me just start with the first question. Which of these is true about the cleft lip? So please pay attention to the question. It is asking about the true statement regarding cleft lip. Okay. So the options are most commonly associated with the congenital syndrome, more common in the females, bilateral cases are more common, and left side is more common than the right side. Okay. So four options are there and we have to go with the best correct answer. So exactly I want to explain, I would like to firstly explain the things and then we will come up with the options and we will mark the right answer. So if I talk about the cleft lip does not affect the palate. We are talking only of the lips being affected. And exactly, if I talk about the cleft lips, it is seen either a small gap, which the gap can be either partial or can be incomplete or can complete here. And it occurs on the one side or can be a bilateral case also. So we are able to get both type of cases, bilateral and unilateral cases. And the reason of or the cause of formation of cleft lip is the failure of fusion of two processes that is called as maxillary and medial nasal process. So if I talk about the failure of fusion of two important processes which doesn't fuse, which lead to the formation of cleft lip, is the fusion of maxillary and that of medial nasal process. That will ultimately lead to the formation of primary palate. Now, there are various types of cleft lip. We have got unilateral incomplete type. We have got unilateral complete type. We have got bilateral complete type as shown in this images. Okay. Now, if I talk about, I would like to discuss the epidemiology of cleft lip. The annual incidence of cleft lip is ranging from 1 per 4,000 to 1 per 10,000 birth. That means it's quite common. And it is occurring in between various geographic condition and ethnic group. Actually, one of the most important point which was mentioned as in the MCQ. So I got Sandeep with the answer. Actually, I will come up with the right answer. Cleft lip is more common in the boys as compared to the girl, and it is frequently seen in the left side. So you just mark this as an important point, that it is common in more in boys and as compared to the girls, and it is more common on the left side. I think one of the option was definitely about this, and if you will see this option, it's definitely that left side is more common than the right side. So definitely, as I got Sandeep Mahata has given the right answer, that left side is more common than the right side. Other than that, if I talk about the most commonly associated with congenital syndrome, it is also not true. It is not the most commonly associated with the congenital syndrome. More common in females. It is more common in the males, as I told you. And unilateral, bilateral cases are both seen. Unilateral is more common. Now, if I talk about the clinical description of the cleft lip is paramedian in location at the level of philtrum, and it can has a interruption which can be mucosal interruption or the muscular interruption. The clinical form, if I talk about the cleft lip, it is ranging, it can range from a sometimes cleft lip is also associated with cleft palate, but here in this case only cleft lip has been asked. So etiological or the reason of it is more seen. The reason is it is found in between the 5th to 12th week of pregnancy, and the reason is failure of fusion of the medial nasal process and with that of the maxillary process. Now, cleft lip is isolated non-syndromic anomaly in case of 70% cases. So it was more associated, most commonly associated with congenital anomaly will become a wrong option, because yes, it is non-syndromic anomaly in cases of 70% cases. Remaining 30% of the cases is seen to be associated with one of the factors associated with the congenital syndrome. Non-syndromic cleft possibly is caused by combination. If I talk about the reason of formation of non-syndromic cleft palate, the reason is formation is genetic and environmental factors are there. And also the reason is teratogenic substance being taken during the pregnancy. For example, tobacco, alcohol or drugs has been taken during the pregnancy. So definitely after this, we are quite clear that the right answer here will be left side is more common. So mostly associated with congenital syndrome, we have just discussed that it is not right. In 70% of the cases it is non-syndromic. More common in females is also wrong. It is more common in males, and it is not the case that the bilateral cases are more common. Left side is more common than the right side, so definitely we have got D as the right answer. So okay, Sandeep, Mahata and Pushpender, can we move on to the next MCQ? Okay, let's discuss the next MCQ being asked in the examination. So if you have got any doubt, you can just write in the message. Now, this was the second question which I want to explain. Which of the following artery nerve is passing through the structure marked with the arrow? Okay. So you have to tell me the right answer. So firstly, the thing is that you have to identify the green color structure. So everyone, before going into the options, can you tell me which is the green color structure? So exactly the green color. So here the green color ligament. So here firstly we have to identify the green color membrane and the ligament, and you have to tell me which nerve and artery or vessel is traversing, is piercing this membrane. So anybody remembers what is the name of this membrane? Anyone? It's very easy to understand. Actually, options are there. Firstly, you try it, then I will tell you the name of the membrane. All of you, please make a try. Which membrane is this, or which ligament is this, and the structure being piercing this membrane will be discussed subsequently. So yes, can anybody here? Sandeep is there, Pushpendra is there. Can you tell me exactly which membrane is this? Actually, the name of the membrane is thyrohyoid membrane. So I was asking for it. Thyrohyoid membrane is there. And if I talk about how we are going to identify this is thyrohyoid, so let me just enlarge this image. So when I'm enlarging it, I just outlining this bone. This is the hyoid bone, and this is the two laminas and the greater and lesser corona. This is the thyroid cartilage. Okay, now it is clear the green color membrane is connecting, and it is connecting two important structure. It is connecting the hyoid bone and the thyroid cartilage. So what is this green color membrane? This is thyrohyoid membrane. So I got a yes. So yes, Nitika is absolutely right. So yes, Nitika, you are absolutely right. You are absolutely right. And you, so a thumbs up goes for you. Thyrohyoid membrane. Nitika Bora is absolutely right. This is the right answer. This is thyrohyoid membrane. Now, exactly if I talk about the nerves and the vessels piercing thyrohyoid membrane, the correct answer will be, it is pierced by internal laryngeal branch of the superior laryngeal nerve. So exactly the thicker median section of the thyrohyoid membrane is the called as thyrohyoid ligament, and thinner lateral side is more thinner, and it is pierced by superior laryngeal internal branch of superior laryngeal nerve. So that means internal laryngeal nerve, and we know that internal laryngeal nerve is a branch of superior laryngeal nerve. It's a branch of superior laryngeal nerve. So this is clear that internal laryngeal nerve will be the branch of superior laryngeal nerve. Other than that, also the artery is piercing this. So thyroid membrane is attached to the lower aspect of the, it is attached to the upper border of thyroid cartilage and to the hyoid membrane superiorly. It is attached to the greater corona of hyoid bone and the margins of the surface of the body of hyoid bone, passes posterior to the body of hyoid bone. Actually, we have got important structures piercing one nerve and the vessel. So in the middle, if I talk about the middle part of the thyroid membrane, it is more thicker as compared to the lateral aspect, and the middle part of thyroid membrane is called as median thyrohyoid ligament. Median thyroid ligament. The lateral portion of the thyroid membrane is more thinner, and it is pierced by superior laryngeal vessel. superior laryngeal vessels and internal branch of superior laryngeal nerve. So these are the two structures. That means superior laryngeal nerve, internal laryngeal branch is piercing it, and also the artery we can see here. So we have got the superior laryngeal nerve and artery as in the diagram. So here we can clearly see the thyroid membrane, which I am highlighting in the green color. This thyroid membrane is connecting the hyoid bone and the thyroid cartilage. In the midline, the thyroid membrane is thickened, and this thickening of the thyroid membrane in the midline is called as median thyroid ligament. Is called as median thyroid ligament, and the lateral aspect it is called as the lateral thyroid ligament. Lateral thyroid ligament. The structures piercing it. So if I talk about the structures which is piercing it, we have got a nerve and we have got an artery. So the nerve and the artery is superior laryngeal nerve and artery. To be more specific, it is the internal laryngeal branch of the superior laryngeal nerve. So we have got the right answer. It is internal superior laryngeal nerve is the right answer here. Okay. Now let's move on to the next question. So we have done with the second question. Now let's move on to the third MCQ. So question number third. A full term delivery boy has unilateral cleft lip. A full term delivery boy has got unilateral cleft lip. The parents are concerned and want to know the cause of it. What is the reason of it? The embryological basis of the defective fusion, which is resulting in a unilateral cleft lip. Actually, that means if I talk about unilateral cleft lip, they have asked two questions regarding these MCQ, because just now we have seen one more question about the unilateral cleft lip has been asked, and this is another question asked from the topic, so that we have to know what is the reason of formation of unilateral cleft lip. The options given is globulomaxillary process with that of the maxillary process, median nasal process with that of the maxillary process. Then we have got lateral nasal process with maxillary process, and maxillary and mandibular process. So question number 3, we have to mark the right answer. If you correlate with the just the explanation which I have given just now, the defective fusion. So I got a right answer from Sandeep Mahata. Yes, so median nasal, and also Dr. Sonali Verma has given the right answer. So thumbs up goes for you. Median nasal process is not fusing with the maxillary process. Pushpendra, Nitika Bora, everyone has given absolutely correct answer. Medial nasal process is not connecting or uniting the defective fusion with that of the maxillary process is the reason. Now, quickly, we will talk about cleft lip, different types. We will just recapitulate it. So, if I talk about cleft lip, it is commonly seen in the case of upper lip. The incidence of cleft lip is 1 per 1,000, and 60 to 80% of the children is involved is male. So, in the previous, Dr. Sujay Singh is absolutely right. In the previous question also, what we have discussed, and we have seen that cleft lip is more common in the left hand side, and it is more common in the males. So if I talk about the various types of the cleft lip, upper lip, the varieties of the cleft lip which we find is unilateral cleft lip, and unilateral cleft lip has been asked in the MCQ, and it is due to the defective fusion of maxillary process with the medial nasal process of the same side. The bilateral, if I talk about the bilateral case, it is the defective fusion of maxillary with that of the frontonasal process, Now, central cleft lip or hair lip, that is occurred due to the failure of development of the philtrum part of the upper lip from the frontonasal process. Where very rarely, if I talk about very rare cases, we have got two mandibular process. Rarely the two mandibular process fail to fuse in the midline, and this will lead to a case of cleft lower lip. But it is quite rare that the cleft lower lip is formed. Now, types of cleft lip, we have got unilateral upper cleft lip, which has been asked in the MCQ, defective fusion which between the defective fusion which has taken place here between the maxillary process and that of the medial nasal process. Bilateral, because of the frontonasal process not uniting with that of the maxillary process. and we have got median upper lip, and very rarely we have got the cleft lower lip, which is also called as the cleft lower lip is also called as the other process in which the mandibular process is not fusing in the midline, which is quite rare. And if there is a central cleft lip, it is also called as hair lip. So we have done with all these options. So let's also talk about another option, another question which has been asked, which is important for your MDS examination, is to know about oblique facial cleft. The oblique facial cleft is also called as orbitofacial fissure. So here in this diagram, you can clearly see this is the oblique facial cleft. And if I talk about the oblique facial cleft, it's a rare congenital anomaly which occurs when the maxillary process is not uniting with it is not uniting with the lateral nasal process. So maxillary nasal process is not uniting with the lateral nasal process. It's a rare congenital anomaly. The lateral nasal process not fusing with the maxillary process, and it can, if we talk about this non-fusion, it can extend till the medial aspect of the angle, and it can extend till the level of upper lip. Consequently, if there is a case of oblique facial cleft, consequently what happens, the nasolacrimal duct is exposed to the exterior, and this anomaly is usually bilateral. Now, let's talk about the cleft palate. If I talk about the cleft palate, the defective fusion of various segments of cleft palate give rise to clefts in the palate, and various degree of cleft palate has been described here. We have got a complete cleft palate. If I talk about a complete cleft palate, it can be either unilateral. In case of unilateral cleft palate, there is defective formation of the premaxilla. So here maxillary process of one side, the maxillary process of one side is not fusing with the premaxilla, and it is always associated with cleft lip. That means cleft lip and cleft palate is associated with each other. So we can see the complete cleft palate unilateral and bilateral as shown in the image. The bilateral occurs if the maxillary process is not fusing with the premaxilla, and it can be divided by a V-shaped cleft, as you can see in this image, separating the premaxilla from that completely as shown in the diagram. Now, incomplete or the partial cleft palate, we have got several varieties of incomplete or partial cleft palate. We have got bifid uvula, in which only the uvula part is involved, and it is not much of clinical importance, not much of abnormality is seen. The cleft palate of the soft palate is involving the uvula and the adjoining part of soft palate. And if I talk of the cleft palate of soft palate only, involving the whole of soft palate, it can also extend into the hard palate. So these are various varieties of the cleft palate. Incomplete or partial cleft palate has been shown here as in the diagram. The case A is bifid uvula. Case B or the image B, which has been shown in this diagram as shown, is the cleft palate of soft palate, and C is the cleft palate which is also extending to the hard palate as shown in the image. So we are done with the question number 3. Let's move on with the next question, that is question number 4. So let's start with the next question, that is question number 4. Level of thyroid gland is, what is the level of thyroid gland? So I will just wait for a few seconds so that you can give me the right answer. Level of thyroid gland is, what is the level of thyroid gland? Option A is C3 to T1. Option B, C4 to T1. Option C, C5 to T1. Option D, C6 to T1. Yes, Ritika. Yes, you are absolutely right. The teratogenic effect. Yes, Ritika, you are absolutely right. Teratogenic effect is also there. So I got an answer from Dr. Sonali Verma and Nitika Bora. They are telling me the answer as C. What about Dr. Sujay Singh is also telling the answer is C. Actually, let me just check. Okay. So most of you and all of you are telling that is yes. So one of the extent of thyroid gland, we know that thyroid gland is a bilobed structure having two lobes, one on either side, lateral lobes, which is connected in the midline by the isthmus, and it is lying in the anterior aspect of the neck. So exactly if I talk about the correct answer, it is extending from C5 cervical vertebra to that of T1 thoracic vertebra. So exactly, thyroid gland is located at the lower part of the front and the sides of the neck opposite to C5, C6, C7 and T1 vertebra, clasping the upper part of the trachea. Now, I want everybody also to see a diagram. So yes, everyone is absolutely right. Pranali, Dr. Sonali Verma, Ritika, everyone has given the right answer. Now, parts and extents of the thyroid gland has been shown. Before proceeding to the next MCQ, I would like to just quickly tell you about the thyroid gland. So here we can see in this diagram, the hyoid bone has also been shown. Okay. Now, exactly the vertebral levels corresponding to the location of thyroid gland as shown in this diagram will be that of C5, C6, C7, and T1. And here in this diagram, if I just concentrate only on the thyroid gland itself, not onto the other part. So you can see that thyroid gland is having two lateral lobes, and the connecting part of the two lateral lobe here we can see this is the isthmus part. Now, from the isthmus part, we can see a small protrusion is there that is called as the pyramidal lobe, which is connected by a fibromuscular band. And via this fibromuscular band, which is highlighted here, this is the fibromuscular band, which is connecting the pyramidal lobe to that of hyoid bone. And this extension of the connection is called as the levator glandulae thyroidae. What is it called as? Levator glandulae thyroidae. So as the question was direct about the location of the thyroid gland, which is exactly at the level of C5, C6, C7, and T1. So, and also what is the covering, outer covering? Yes, Ritika, you are absolutely right. There are four parathyroid gland, which is located on the thyroid gland on the posterior aspect. Now, other than that, can anybody tell me what is the covering of thyroid gland? What is the outer covering of thyroid gland? Which layer of deep cervical fascia is forming the false capsule of the thyroid gland? Can anybody tell me that? Which layer of deep cervical fascia, which layer of deep cervical fascia is forming the false capsule of thyroid gland? My question is, which part of deep cervical fascia is forming the false capsule of thyroid gland? So as we know that yeah, if I talk about the deep cervical fascia, it is having three layers as you proceed from outside to inside. That is the investing layer of deep cervical fascia. We have got investing layer, we have got the pretracheal layer of deep cervical fascia, and we have got the prevertebral layer. I got an answer from Nitika Bora. She is telling pretracheal layer. She is absolutely right. And Anirudh R is absolutely right. Dr. Shruti is absolutely right. All of you are absolutely right. The correct answer is pretracheal layer of deep cervical fascia is forming the false capsule of thyroid gland. False capsule of thyroid gland. And can anybody tell me when the thyroidectomy operation has to be performed, the incision is given between true and false capsule or interior to true capsule? Can anybody tell me? So exactly what happens, the true capsule of the thyroid gland is formed from the fibrous condensation of the tissues, and we have got false capsule which is formed by the pretracheal layer of deep cervical fascia. So exactly the location of thyroid vein is lying interior to the location of thyroid vein is lying interior to that of the pretracheal layer. And if we want to preserve the thyroid vein, we will give a surgical incision which is given so that we are going to save the thyroid gland veins there, so it will be given in between the false and the true capsule of thyroid gland. So is it okay, everyone? Can we move on to the next MCQ to be asked in the exam, has been asked in the examination? I hope most of you have given the right answer. Okay. Yeah, so let's move on to the next question. Okay, now let's move on to the next question. So here we have got question number 5. A person comes after RTA with blindness. Okay. RTA means road traffic accident. What is RTA? Road traffic accident. What is RTA? Road traffic accident. On MRI examination, you see there is an aneurysm which is compressing the optic chiasma. The aneurysm is lying very close to the optic chiasma. Which of these vessel is most likely the reason of the cause of aneurysm? So we have got four options given here. The options are anterior. Okay, so anterior communicating artery, posterior communicating artery, anterior choroidal artery, and middle meningeal artery. Okay. So yes, I got Dr. Sujay Singh is telling levator glandulae. Explain, ma'am. Okay. So yes, many of you have. So is it okay, Dr. Sujay? We can come to your doubt after just solving this MCQ, because few of the students has already given the answer. Sandeep Mahata is telling A and Nitika Bora is telling A, anterior communicating artery. So firstly, let's solve question number 5, and then I will come once again for the explanation of levator glandulae. Okay, dear. Okay. So most of the students are giving anterior communicating anterior, they are telling anterior communicating artery. Actually, absolutely correct. Anterior communicating artery is absolutely, A is absolutely correct answer. So exactly, if I talk about anterior communicating artery, it's absolutely correct answer. Actually, more of the arteries are also involved, but clearly the option which is not taking any doubt here is the posterior communicating anterior choroidal middle meningeal artery is not involved. So exactly, we will go absolutely with the right answer here, and the right answer is anterior communicating. Actually, vascular compression of optic chiasma will lead to a defect in the vision, and the defect is called as bitemporal field defect. Bitemporal field defect. Now, the aneurysm which is compressing ACA, when I am talking about the important option of aneurysm being important option of the aneurysm being compressed, the options will be, there is involvement of anterior cerebral artery ACA. Please note down, ACA here stands for anterior cerebral artery. ICA for internal carotid artery, and anterior communicating artery. So three arteries are involved. Three arteries are involved. That is ACA, anterior cerebral artery, bitemporal visual field defect is there, and the arteries being involved is anterior cerebral artery, internal carotid artery, or anterior communicating. Among the options given here, we have got the correct answer as anterior communicating artery, because other options that is not involved in the case of the aneurysm which is located at the level of optic chiasma. So all other options are wrong, and we will go with A as the right answer. Other than that, I would like to just slightly elaborate about the aneurysm or saccular aneurysm or berry aneurysm, which is present in the general population of a range of 1 to 2%. The aneurysm is congenital and degenerative because of weakness of which layer? There is weakness of tunica media layer. We know that the vessels are having tunica intima, media, and tunica adventitia layer as you proceed from inside to outside. So the stress is due to the blood pressure. So the reason will be the person is suffering from high blood pressure defect, cigarette smoking, and other factors, which is the weakening the tunica media layer and can lead to the aneurysm formation. So if I talk about the berry aneurysm, the site of the arterial branching may occur at many sites. But if I'm talking about the cerebral aneurysm, be involved, the more commonly involved area will be the circle of Willis. So there are three important junctions which is mainly involved. We talk about anterior communicating artery with anterior cerebral artery, which is involved in 30 to 35% cases. Also posterior communicating artery with that of internal carotid artery, middle cerebral artery involved in 20% cases, and 15% of the cases also posterior inferior cerebral artery will be involved. But if here the option was given about the location of optic chiasma, so definitely we will go with the most correct answer, that is lying close to it is the anterior communicating artery, A option. So definitely we have got A as the correct answer. Now, next question is question number 6. But before that, I think Dr. Sujay Singh want me to explain levator glandulae and Lugos solution use. So, if I talk about Lugos solution, it's a solution of potassium iodine, and it is used as an antiseptic. So, it is used as an antiseptic for the diagnosis of cancers also. So, it is used for the cancer diagnosis also. Okay. So, is it okay? So, I think Ritika, your Lugos solution doubt has been done. And what about Dr. Sujay Singh? Okay, so let me move with that. So you can see from the pyramidal lobe, you can see there is an extension from the pyramidal. Sometimes there from the pyramidal lobe, there is a fibromuscular glandular structures extending. Fibromuscular extension is there, which is connecting the extension of the isthmic from the isthmic part of the thyroid gland, you can see the pyramidal lobe is an extension protruding in the upward direction. It is connected to hyoid bone via connecting fibromuscular band, and that band is called as levator glandulae thyroidae. That connection between the hyoid bone and the pyramidal lobe is called as levator glandulae thyroidae. Is it okay? So let me just check your chat box. Is it okay, Dr. Sujay Singh and Dr. Ritika? Can we move on to the next MCQ? Everyone, so let's move on to the next MCQ. So I think many of the questions, so I would like to tell that also the previous at the DBMCI platform, more of the educator has already solved the MCQs of their subject. So I think many of the MCQs were directly asked from the notes, and exactly cleft lip question was directly from the notes, and many of the questions is from that notes itself. So you must have solved it right, I think. Nitika Bora, okay dear. Okay dear, so let's move on to the next question. Now question number 6. All are the symptoms of facial paralysis except, all of the following are the symptoms of facial paralysis except loss of salivation, option A, loss of lacrimation, option C, facial muscle paralysis, and loss of taste sensation in posterior one third. So taste sensation is in the tongue. So definitely it is asking about the tongue. So four options are there, and I want firstly everybody to answer this so that I can come up with the explanation. Okay, all are the symptoms of facial paralysis except four options are there. Sonali Verma, Shruti, Sandeep Mahata, Nitika Bora, Ritika. So everybody is giving me D as the answer. Okay. So all of you are absolutely correct. Can you tell me loss of taste sensation on posterior one third part of the tongue is gone when which nerve is involved? So can you tell me the nerve being involved if it is if the presentation of the patient is loss of taste sensation in posterior one third part of the tongue? So can you tell me the involved nerve name? Question number 6. Please mark the right answer. So Nitika is telling it's the glossopharyngeal nerve. Sandeep Mahata is telling it's the ninth cranial nerve. Absolutely correct. If we talk about the loss of taste sensation in the posterior one third part of the tongue, the involved nerve will be glossopharyngeal nerve. Glossopharyngeal nerve. Absolutely correct. Absolutely correct, dear. Yes, glossopharyngeal nerve is absolutely correct answer. So other than that, loss of salivation, loss of lacrimation, and facial muscle paralysis is obviously present in the case of facial nerve injury. So firstly, I want to just recapitulate. So everyone is right. Firstly, I want everybody to recapitulate about the innervation, both motor and sensory innervation of the tongue. So I'm just enlarging this image so that you can see one side there is motor nerves and other side there is sensory nerve. So if I talk about the motor innervation of the tongue muscles, so we can just know all the muscles of the tongue is innervated by hypoglossal nerve except palatoglossal. Palatoglossal nerve is innervated by vagus nerve. Along with the vagus nerve, the cranial part of accessory nerve is traversing. So all the muscles of the tongue, if I talk about all the muscles of the tongue, they have got innervation by hypoglossal nerve. So I will just give you the recapitulation of it. Other than that, let's talk about the sensory innervation. For understanding the sensory innervation, the entire part of the tongue is divided. So this V-shaped sulcus which you are seeing is the sulcus terminalis. Now the sulcus terminalis will divide the dorsum part of the tongue into anterior two-third part and posterior one-third part. This is the posterior one-third part. Now, if I talk about anterior two-third part, the general sensation is via lingual nerve, which is a branch of mandibular nerve, which is a branch of trigeminal nerve. If I talk about the posterior part of the tongue, along with this big papillae. What is this beak papillae? These are the circumvallate papillae. So circumvallate papillae along with the posterior part, one third of the tongue, is getting both sensory and that of general sensation via glossopharyngeal nerve. And posterior most part of the tongue is getting innervation via vagus, the internal laryngeal branch of vagus nerve. So this is very important for you to understand. This has been asked several times in the previous year also. So let me just quickly write it and then we can proceed to the facial nerve injury. All the muscles of the tongue. So you just write all the muscles of the tongue is innervated by, all the muscles of the tongue is innervated by hypoglossal nerve, that is 12th cranial nerve, except palatoglossus, except palatoglossus muscle. The palatoglossus muscle is innervated by vagus nerve carrying the part of cranial accessory nerve, carrying the part of cranial accessory nerve, carrying the part of cranial accessory nerve. So done with this. Now, so this was about the motor. Now I would like to talk about the sensory innervation. So let's talk about the sensory innervation. So we have already talked, this was about the motor innervation, and now we will talk about the sensory innervation. When I'm talking about the sensory innervation, anterior 2/3 of tongue, general sensation is via lingual nerve, and my dear students, the lingual nerve is a branch of, can anybody tell me lingual nerve is a branch of which nerve? Lingual nerve is a branch of mandibular nerve, and mandibular nerve is a branch of trigeminal nerve. So this is about the general sensory innervation of anterior 2/3 part of the tongue. Now talking about special taste sensation. If I talk about special taste sensation in the anterior 2/3 part of the tongue, the special taste sensation, yes, absolutely right, Nitika, you are absolutely right. The special taste sensation is via coda tympanic nerve, and we know that coda tympanic nerve, can you tell me it's a branch of which nerve? Coda tympanic nerve is a branch of which nerve? Coda tympanic nerve is giving special taste sensation to anterior 2/3 part of the tongue. So coda tympanic nerve is a branch of facial nerve. So done with this. Now I would also like to talk about the posterior 1/3 part of tongue. So when I'm talking about posterior 1/3 part of the tongue, both absolutely correct, Nitika and Sandeep, both taste sensation and general sensation. Absolutely correct, dear. Both taste sensation and general sensation is via ninth cranial nerve, that is glossopharyngeal nerve. Ninth cranial nerve, that is glossopharyngeal nerve. Now, here you can also add on one point, the circumvallate papilla. So this posterior 1/3 part along with the circumvallate papillae. The circumvallate papilla is exactly located anterior to sulcus terminalis, but its innervation is via ninth cranial nerve only. And if I talk about posterior most part of the tongue, so if I talk about posterior most part of tongue close to the epiglottis, the laryngeal cartilage, it is innervated by internal laryngeal nerve. And we know that internal laryngeal nerve is a branch from the superior laryngeal, which is a branch from the vagus nerve. So both here also posterior most part of the tongue, both general sensation and special taste sensation is given by the internal laryngeal nerve branch of the vagus nerve. So done with this. Now let's talk about the facial nerve. Its course distribution is shown here. Course and distribution. Let me slightly enlarge this image. So I'm slightly enlarging this. So here we know that facial nerve, which is emerging out from the pontomedullary junction, and it is giving a greater petrosal nerve. The greater petrosal nerve, the first branch from the facial nerve, which will join the greater petrosal nerve here. I just want to explain one by one. So I'm just firstly going with the first branch, that is greater petrosal. Greater petrosal nerve is going to join with the deep petrosal nerve, forming the nerve of pterygoid canal, which is innervating the lacrimal gland. So that is important for the lacrimation and tear secretion. The other branch here given is nerve to stapedius. So nerve to stapedius means it is having important effect of dampening down the loud sound, and if this is injured, the dampening down effect of sound is gone, and whispering will also be heard like a loud sound. Okay. Other than that, it also gives coda tympanic nerve, joins with the lingual nerve, and ultimately gives innervation to submandible. They are important for the secreto. So exactly coda tympanic nerve along with joined with the lingual nerve, it is important for the secretomotor fiber secretion from submandibular sublingual gland. We have got other branches emerging from the stylomastoid foramen, posterior auricular, which is supplying the occipital belly of occipitofrontalis, give innervation to posterior belly of digastric, and we have got temporal, zygomatic, mandibular, and cervical. These are the terminal branches of the facial nerve, which is emerging out from the anterior border of parotid gland like spex and serine, and these are innervating the muscles of facial expression, which is very important for the facial expression. So that means muscles of facial, that means there will be ipsilateral paralysis of the muscle. So all infranuclear lesion which involves the face on the same side, the sign and symptoms differ according to the site of location. So if I am talking about the site of location, just above the stylomastoid foramen, that is A. So that is just above, it causes lower motor function loss of all the muscles will be paralyzed for the facial expression. All the muscles will be paralyzed, and deviation of mouth towards the normal side, inability to close the mouth, eye, accumulation of food in the vestibule of mouth, and flattened expression. The person will not able to give a expression, facial expression. These are when there is location of the site when the facial nerve is emerging out from the stylomastoid foramen. From the stylomastoid foramen. So done with the site A. So we have done with the site A. So this was about the site A. Let's talk about the origin above coda tympanic nerve. That means signs of Bell's palsy will be there. That is all the facial muscle expression has been paralyzed. Along with that, there will be also affection of salivation, loss of taste in the anterior two-third part of the tongue. We know that coda tympanic nerve is innervation for carrying taste fibers for the anterior two-third part of the tongue. Other than that, if the location of injury is above the origin of nerve to stapedius, that means along with the other symptoms, along with the paralysis of all the muscles of facial expression, secretion of the submandibular sublingual gland, and taste fibers of anterior two-third will be affected. Along with that, also the stapedius muscle will be paralyzed, and there will be hyperacusis. Enhanced sensitivity will be there of hearing, and whispering will be also felt like a loud noise. If the injury is at the level of geniculate ganglion, that means all the signs and symptoms, that is a stapedius muscle will be paralyzed, hyperacusis, facial muscle paralysis, ipsilateral side, secretion of submandibular and sublingual gland is gone, anterior two-third of the tongue taste sensation is gone. Along with that, also the lacrimal gland lacrimation will be affected. So this is when the lesion is at the site of geniculate ganglion. So done with this. So clearly the right answer is D, which most of you have marked right. All of you are marked right. Let's move on to the next. That is question number 7. So, okay, let's move on to the next question. That is question number 7. So, where is the mental foramen typically situated in case of elderly individuals? Option A, near superior border of mandible, near inferior border of mandible, in the center of alveolar ridge and lower border, and near the symphysis region. So, we have got 4 options and you have to mark the right answer. So those who are live, they can give me the right answer. What is the level of mental foramen? So this is a question asked from the mandible, and when it is in case of elderly individual, near the superior border of mandible, near the inferior border, in the center of alveolar ridge and lower border, or near the symphysis region. So multiple answers are coming. So Shruti has told A. D. Nitika Bora, Gautam, Dr. Sujay Singh is telling A. So we have got mixed bundle of answers. Let me come up with the explanation. Actually, there is certain features of difference when you see the mandible of a child, of an adult, or an old person. So there is certain features which is different for these three age group person. So we will talk about the difference of the mandible in these three age group person. Okay. So here, age changes in the mandible. So I'm just enlarging this. Here we can see age changes in the mandible. Age changes in the mandible. So if I talk about the age changes, there are three columns. There are three differences which is seen. Basically, there are four important differences in children, adults, and old age. So let's talk firstly about the mental foramen, which has been asked in the MCQ. If I talk about the mental foramen location, is present close to the inferior border of the body of the mandible in case of children. So that is the case of a children. In adults, it is midway between the upper and the lower border of the body of mandible. And in older person, it is close to the upper border. So what has been asked in the MCQ was about the older or elderly person. So definitely the right answer will be close to the upper border. So this is close to the upper border. That means definitely near the superior border is the right answer. So most of you have given A as the right answer, and definitely you are right. Yeah. Other than that, the angle of mandible also deviates. So if I talk about angle of mandible deviation, will be 140 degrees in case of children, will be 110 degrees deviation in case of adults. And again in old age, it is 140 degrees. That means child and the old age person are similar. Now, coronoid and condyloid. Coronoid process is lying above the level of condyloid process in case of children. Condyloid lies above the level of coronoid process in case of adults also. So there is a difference in this which is important for you to note down. Please don't write down. In case of children, coronoid process above the level of condylar process. Condyle is above the level of coronoid. So that is different. They are not corresponding. Coronoid is above in children and condyloid is above in adults. Coronoid process above the level of condyloid in case of old age. So that is also similar in case of children and adult. Children and old age. Mandibular canal runs lower near the lower border, and it will run parallel to mylohyoid in case of adults, and it will run close to the upper border. That means in case of elderly person, the mental foramen and also the mandibular canal, all other structures is running very very close to the upper border, and that was exactly asked here. So exactly, if I have to mark the right answer, mental foramen typically located in case of elderly person, the right answer will be it is lying near the superior border of mandible. So A is absolutely right answer. Near the inferior border is seen in case of children's. In midway, it is seen in case of adults. So we have got the right answer. Question number 7, we have got the right answer A. Okay. So can we move on to the next question, everyone? Can we move on to the next question? Puspender, Preeti, Gautam, Nitika, Sandeep, Parul, Dr. Shruti, Sandeep, Nitika, Bora. Next question. So let's come to the next MCQ here. Let's come to the next one. Which of the following is not cell to cell junction? Which of the following is not a cell to cell junction? Desmosomes, hemidesmosomes, adherence junction, or tight junction? Question number 8. So all of you, please mark the right answer. Let me just check. Have you marked it right or not? Okay, so hemidesmosome, Dr. Shruti Lai is telling hemidesmosome, Dr. Sujay Singh is telling B hemidesmosome. Preeti and Sandeep, Nikita Bora, everyone is telling hemidesmosomes. Okay, so it is very important that we should understand exactly what is desmosomes, what is hemidesmosome, what is adherent junction, and what is tight junction. Most of you are again right. Hemidesmosome is right. Actually, this is a question from the histological aspect, histology, and most of you are completely right here. But I would like to elaborate so that you can have the understanding that what does we mean by desmosome, what does we mean by the hemidesmosome, adherence junction, and tight junction. So one by one, I will explain this. Now, if I talk about the cell junction, actually the most key factor which you have to note here, actually both are forming, all the options given here is forming junctional junctions. But here the specific thing which has been asked is cell to cell junction, cell to cell junction. So exactly cell junction or junctional complexes are the class of cellular structures which is consist of multi-protein complexes, and this multi-protein complexes is providing contact and adhesions which is taking place between the neighboring cells. Okay, so exactly uh, we have to understand what type of junction, cell junction or junctional complexes are there. Exactly, the junction is between the cellular contents, and it is between the cell to cell. And exactly, they also maintain, what is the other function of these junctional complexes is they are maintaining the paracellular barrier of the epithelium and controlling the paracellular transport. This is highly important and very, very important for you. Now, exactly all the options were seeming, if you don't pay attention to this, you will not understand why we are picking the hemidesmosome as the right answer, because all of these are a kind of cell junction. But exactly in the MCQ, it has been asked cell to cell junction. So if I talk about the cell junction, they are adherence junction, desmosomes junctions, hemidesmosome junctions, gap junctions. Exactly, if I talk about the junction, there are three types. There is anchoring type of junction. There is an anchoring junction, there is a communicating junction, and there is an occluding junction. Three junctions are there. When I am using the word occluding junction, the word occluding junction example will be tight junction. The communicating type of junction is the gap junction, and the junction which is anchoring type in nature is the adherence junction, desmosome, and hemidesmosome. Now, desmosome is also called as a binding body. It is also termed as a bonding body, which is also known as macula adherens, and it is acting as an adhering point, which is specialized cell to cell junction. So definitely it will not be the right answer, because exactly it is forming cell to cell adhesion. Desmosomes are acting as an adhesive intercellular junction. It is mainly coupling the adhesive interaction which is taking place between the desmosomal adherence to that of intermediate filament of the cytoskeletal network. Okay, so that means if I talk about a desmosome, it is a type of macula adherens which is forming cell to cell adhesion. And here you can see the image where to cell adhesion, which is acting as a macula adherens, is the desmosome. So definitely it is not the right answer. Exactly, cell to cell adhesion is its function. If I talk about adherence junction, Jonah adherence, and protein complexes that occur. So Jonah adherence, which is also called an adherence junction, it is cell to cell junction between the epithelium and endothelial tissue. So definitely Jonah adherence, which was given as an option, is also not the right answer, because it is also forming cell to cell junction and cell matrix junction. Now the next is the tight junction. So one of the option was tight junction. If I talk about tight junction, it is a type of occluding junction. It is a type of occluding junctions. So if I talk about occluding junction, it is made of multi-protein junctional complexes, which is preventing the leakage of solids and waters, and it is sealing the epithelial tissue. The role is very critical. If I'm talking about the tight junction, it is very important for you all to note down that it's very critical in maintaining the structural permeability of the endothelial cell. So you can see this is the tight junction acting as an occluding junction, and it is exactly preventing leakage of any solids taking place between the cells. So that means tight junction is also in between the cells. Adherent junction is also, that is Jonah adherence, is also between the cells, and the desmosome is also is a junction between the cell. So we have got the odd man out, that is the hemidesmosome. So let's talk about the hemidesmosome. So if I talk about hemidesmosome, it is a multi-protein complexes that is facilitating the stable adhesions of the basal epithelial cells, and it is connecting the basal epithelial cells to underlying basement membrane. So exactly, it is not exactly between cell to cell. Hemidesmosome, if I talk about the adhesion which is taking place in case of hemidesmosome, it is between the basement membrane and the cell. So it is exactly between the epithelial cell and the basement membrane. So only it is the odd man out and is the right answer here. So we will mark the hemidesmosome as the right answer. The mechanical stability of hemidesmosome relies on the multiple interaction which is taking place between the protein component, and it is forming a membrane embedded tightly ordered complexes. So here also you can see the hemidesmosome is binding the epithelial cell to that of basement membrane. It is not exactly taking place between cell to cell. So the correct answer, which all of you have already marked it, is the hemidesmosome. So a thumbs up goes for you, those who have marked it as the right answer. Okay. So that is absolutely correct. Let's move on to the next. So can we move on to the next question? That is question number 9. So exactly, actually, I have framed a clinical question. Exactly, one of the question which was asked was about spinal accessory nerve. Some procedure was done in the posterior triangle of the neck, and then the paralysis of and the clinical abnormality was presented. And exactly, I was not remembering the option, and after going through many of discussion, I found there was one option, spinal accessory, or maybe if you all remember, can you help me in this MCQ? Sandeep, Mata, and everyone, can you help me? The option was like this, or was the option was different? I would like to read this clinical question for you. A 67-year-old woman is admitted to the emergency department with a severe swelling on the right side of her neck. An MRI examination is done to reveal the abscess. The abscess is surgically removed from the middle of the posterior cervical triangle on the right side. During recovery, the patient noticed that her shoulder droops and she can no longer raise her right hand above her head to brush or comb her hairs. Which of the following nerve is most likely injured in this case? The option given is option A is spinal accessory nerve, option B is facial nerve, option C is hypoglossal nerve, and option D is ansa cervicalis. So, as I can see that Sandeep Mahata and Nitika Bora has given the right answer. Spinal accessory nerve is definitely right answer. After RTA, patient presented drooping shoulder. Okay, so Devendra Singh is giving me exactly the literature part of the question being asked, that there was a drooping of the shoulder was given. So here also I have mentioned the patient notices her shoulder droops and no longer. So after RTA, okay, road traffic accident. So it was road traffic accident. Okay, so the question will be framed like that. But I think I have come to the similar type of framing of the MCQ only, because if there is an accident, or if the person is admitted in emergency department for any kind of swelling in the right leg, and if you want to drain that abscess, or if there is a case of road traffic accident and posterior triangle of of neck is affected, definitely the clinical sign and symptoms which is seen in the patient is not able to uh, drooping of shoulder, not able to raise her hand, so overhead abduction. So for combing the hairs, which action is required? Overhead abduction. And we know that overhead abduction of the arm is done by two muscles when acting together, and that muscle is trapezius and that of serratus anterior muscle. So I think everybody is okay, dear. Yes, Nitika Bora. So definitely we know that serratus anterior is gone, or and the trapezius muscle will be gone if this action, abduction above 90 degree has to be done. Here, the location of the injury is in the neck. So definitely spinal accessory nerve, which is giving innervation to trapezius and sternocleidomastoid muscle, has been gone. If the option, can anybody tell me there was an option of cranial accessory nerve there? Cranial accessory nerve was an option or not? Cranial accessory nerve. Cranial accessory nerve. If cranial accessory nerve was also an option there, it is also wrong. I will tell you why. Why it is wrong? Because we know that cranial part of accessory nerve runs along with the vagus, and it is giving innervation to the muscles of pharynx. It is giving innervation to the muscles of pharynx and soft palate. So it is not the right answer. Spinal accessory nerve is the right answer, giving innervation to sternocleidomastoid and trapezius muscle, which is paralyzed in this case. Okay, okay, no, okay. Facial nerve is not the right answer, because if facial nerve is injured, the facial muscles will be injured, and asymmetry of the face will be there, or something related to facial nerve like lacrimation is gone, or secretion of some mandibular lingual gland is gone, taste sensation in anterior part of the tongue is gone. Hypoglossal nerve is not the right answer, because no inclusion of the muscles of the tongue being paralyzed. Ansa cervicalis, we know that it is giving innervation to infrahyoid muscle. Such presentation was not there. So I will go to the next question. Before that, I just want you to brief about the spinal accessory nerve. So let's talk about the spinal accessory. If I talk about spinal accessory nerve, okay, so Devender Singh, okay, Devender, you are telling there was an option of thoracic nerve of Bell. Can anybody tell me what is the other name of nerve of Bell? I think most of you must be knowing nerve of Bell. Nerve of Bell is long thoracic nerve, is long thoracic nerve. And we know that long thoracic nerve is also involved in overhead abduction. But here the injury is in the neck. Okay. So if I talk about long thoracic nerve, generally long thoracic nerve will be injured in which procedure? Can anybody tell me? Otherwise, I am going to explain you. Long thoracic nerve, that is also called as Bell's nerve, nerve to serratus anterior, which is a branch of the root of brachial plexus having the root value C5, C6, and C7. Is it clear? The root value will be C5, C6, and C7. So generally, if I talk about nerve of Bell's nerve or serratus anterior muscle innervating nerve, that is long thoracic nerve, it will be injured when there is a procedure which is performed in the axilla, or the radical or total mastectomy is done, breast removal is done, radical mastectomy is done. So I think that such kind of history, such kind of operation, surgical history was not provided, and exactly the location was given as a neck area. So definitely spinal accessory nerve is the better option. Okay, so we will go with spinal accessory as the right answer. So is it okay, Devendra Singh? Yeah. So spinal accessory nerve crosses the posterior triangle of the neck, and it is spinal accessory nerve is innervating two muscles. It is innervating sternocleidomastoid muscle and that of trapezius muscle. Okay. Now, so upon surgical division of this nerve, the patient will have in the loss of ability of raising the ipsilateral shoulder and demonstrating weakness in turning of the head to the opposite. Trapezius will also lose the tone, and ultimately the shoulder will droop. Okay, dear. So definitely the clinical presentation which was given in the MCQ is corresponding to the injury of spinal accessory nerve. So this is exactly the image of the triangle. Here this triangle which you are seeing, this triangle is the posterior triangle which is having the boundary of sternocleidomastoid muscle anteriorly. Trapezius muscle is the boundary posteriorly. Apex is lying at the level of the occipital bone at the superior nuchal line where the trapezius and sternocleidomastoid muscle is meeting, and the base will be formed by the middle one third of the clavicle. Now, and one of the important content of, if I talk about an important content of posterior triangle, it's the spinal accessory nerve. Spinal accessory nerve is exactly located between the roof and the floor of posterior triangle. And if I talk about the course of spinal accessory nerve, it is traversing between the two layers of deep cervical fascia. Can anybody give me the answer? Which two layer of deep cervical fascia is the nerve traversing? It is traversing between the investing layer and the prevertebral layer of deep cervical fascia. Spinal accessory nerve is an important content of the posterior triangle of the neck, traversing between the investing layer and that of the prevertebral layer of deep cervical fascia, and it is innervating two muscles, the sternocleidomastoid muscle and that of trapezius muscle. Now, facial nerve is not the right answer. Why? Because facial nerve is not located in the triangle of neck. It will cause the paralysis of the muscles of expression. Hypoglossal nerve is also not the right answer, because we know the 12th cranial nerve is innervating the tongue muscle, and not the patient's symptoms which was mentioned in the MCQ. Ansa cervicalis will be also not the right answer, because we know that ansa cervicalis loop is giving innervation to strap muscle, and it is not involved if it is injured causing drooping of shoulder. So ansa cervicalis, if I talk about ansa cervicalis, the ansa cervicalis is basically giving innervation to all infrahyoid muscle except thyroid, except thyroid. So the doubt which you must be wanting to know, which all infrahyoid muscle is innervated by ansa cervicalis loop. Ansa cervicalis loop is embedded in the anterior sheath of the carotid, anterior wall of carotid sheath, and it is giving innervation to all the infrahyoid muscle in superior inferior belly of omohyoid, sternohyoid, sternothyroid, but not the thyroid. Thyroid is innervated by C1 nerve fibers traversing along with the hypoglossal nerve. So definitely we have got the right answer as the spinal accessory nerve. Now let's move on to the next question. That is question number 10. So can we move on to the next question? That is question number 10. Which of the following does not drain into middle meatus? The options are anterior ethmoidal sinus, A. B is middle ethmoidal sinus, C is posterior ethmoidal sinus, and D is maxillary sinus. Which of the following does not drain into middle meatus? So we have got four options and you have to pick the right answer. We have got four options and you have to give me the right answer. So just pick the right answer here. So yes, Sandeep Mahata is telling it's C and Nikita Bora is telling C. So that means we have to know the lateral wall of the nose. The meatus located in the lateral wall of the nose. We know that there is location of superior meatus. There is a location of middle meatus and inferior meatus in the lateral wall of the nose. And we have to know all those sinuses which will be draining into these meatus. So exactly we have to know the sinuses draining into the middle meatus and which of the following sinus is not draining. So I got an answer only from Nitika, Sandeep, and Afrin is also telling it's C. What about others? What about others? Please tell me the right answer. So posterior ethmoidal sinus is absolutely right answer. So what is important for us is to see the lateral wall of the nose, and we will see also the important sinuses draining into it. So we know that number of sinuses are lying around our as the paranasal sinus, and most of this paranasal sinus, all of this paranasal sinus is opening in the meatus of the lateral wall of the nose. So let's discuss that. So Pranay, Shiny, Afrin, everyone has marked it as a right answer. So firstly, I would like to give you the list, the openings in the lateral wall of the nose. So if I talk about the sinuses, sphenoethmoidal recesses, we have got in the sphenoethmoidal recesses, we have got sphenoethmoidal air sinus opening into it. So what opens into it? Sphenoidal air sinus. If I talk about the superior meatus, so posterior ethmoidal air sinus, if I'm talking about posterior ethmoidal air sinus, it opens into superior meatus. It opens into superior meatus. Now, it is also important to know all that structure which opens in the middle meatus. Okay. So, on the bulla, there is an opening of middle ethmoidal air sinus. So, exactly when you will, actually, there are terminates in the lateral wall of the nose. And if you go for the dissection and you see the terminates of the concavs, so what you will see in the middle meatus, there is an elevation in the middle meatus, which is called as bulla ethmoidal ace. So, bulla, on the bulla, there is an opening of middle ethmoidal air sinus, and just below the bulla we have got a semilunar depressed area. That semilunar depressed area is called as hiatus semilunaris. What is it called as? It is called as hiatus semilunaris. In the anterior part of the hiatus semilunaris, we have got the opening of frontal air sinus. In the middle part, we have got the opening of anterior ethmoidal air sinus. In the posterior part, we have got the opening of maxillary air sinus. But now, when we talk about the opening which is taking place in the inferior meatus, we have got the opening of nasolacrimal duct. Okay, so now I would like to just enlarge this image where the same thing I want you to see in this image. So we have got three meatus. This is the inferior meatus, and the structure opening in the inferior meatus is the nasolacrimal duct. In the middle meatus, exactly on the bulla. So I would like to highlight the bulla. On the bulla, we have got the opening of middle ethmoidal air sinus, and below the bulla, we have got hiatus semilunaris. So what is it? This is hiatus semilunaris, and if you will see hiatus semilunaris, you can see various structures opening into it. Frontal air sinus, anterior ethmoidal air sinus, and more posteriorly is the maxillary air sinus. Now, what structure opens into superior meatus? If I talk about the structure opening into the superior meatus, we have got posterior ethmoidal air sinus opening into the superior meatus, and above the level of the superior turbinate, we have got a space which is lying in relation to that of the base of the skull, and that space is called as sphenoethmoidal recesses. The structure opening in the sphenoethmoidal recesses is sphenoidal air sinus. What is it? It is sphenoidal air sinus. So is it clear? Let's move on to the next question. So we have done with the question number 10th. Now let's move on to the next question, question number 11. Identify the fracture shown in the image. So all of you please concentrate on the next question, that is question number 11. Identify the fracture line shown in the image below. We have got an option as Lefort 3 line, Lefort 2 line, Lefort 1, or naso-orbital ethmoidale. So all of you can give me the right answer. I just want everybody to notice this image where you can see the Lefort fracture. This is a image of Lefort fracture. We know that Lefort fracture is having 3 grades. That is Lefort fracture 1, Lefort fracture 2, Lefort fracture 3. So everybody, can you tell me which Lefort fracture is this? So I have just enlarged this image and you have to. So I got an answer from Dr. Sandeep, Dr. Nikita, and Dr. Shruti. Dr. Shruti is telling it is Lefort 2. Okay. So the correct answer is also, my dear students and my dear students, is the Lefort 2. Lefort 2 is absolutely right answer. This was an image-based question asked in your MDS examination 2024. This was the question being asked. I hope everybody has marked it right. Okay. Now, group of mid-facial, if I talk about group of mid-facial injuries which takes place in the maxilla and which is separated from the skull base along with the plane of injury, a combination of Lefort fracture is there which can be categorized, and they can be unilateral or bilateral. So we got a 3 levels of Lefort fracture, that is Lefort fracture 1, Lefort fracture 2, and Lefort fracture 3. What was shown in the image was Lefort fracture 2. Now let me elaborate it. What is Lefort 1 fracture? So in the red line, what you are seeing is the Lefort fracture 1. And if I am talking about Lefort fracture 1, the fracture line is extending through pariform aperture going superior to the maxillary alveolar ridge. Definitely in the image you can see this is the teeth. This is the upper teeth. That is exactly the maxillary alveolar ridge, and the line is above the level of maxillary alveolar ridge. So that is the identification point, and then it is propagating more anteromedial posterolaterally going towards the maxillary sinus wall. So this is which type of fracture? This is the Lefort fracture 1. Now let's talk about the Lefort fracture 2 line. So if I talk about Lefort fracture 2 line, which was given in the image, we can see it is involving posterolateral aspect of the maxillary sinus. So definitely this is the maxillary sinus starting from the posterolateral aspect, and it extends towards the orbital rim. So here in the image also you can see it is extending onto the orbital rim, and it is also involving the orbital floor. Not only the orbital floor, it is also involving the medial orbital wall and the region of nasofrontal suture. So definitely Lefort 2 is the correct answer. So now everyone please concentrate on the Lefort 3 fracture. So when I am talking about Lefort 3 fracture line, as shown in this image, you can see the fracture line is extending through the nasal bridge. It is traversing through the nasal bridge. So this is the nasal bridge. So definitely you can see the red line is crossing the nasal bridge, the medial orbital wall, and the posterior orbital floor, and going towards the frontozygomatic suture. So this is the frontal bone. This will be the frontal bone, and this is the cheekbone. Which bone is this? This is the zygomatic, and this is the frontal. So exactly if I talk about Lefort fracture 3 line, it is going towards the frontozygomatic suture. And one more thing I would like to add on, the zygomatic arch is always fractured in case of Lefort 3 fracture line. So after this explanation, I think everybody is now correctly able to identify the correct answer, that is Leaford fracture 2 line. So is it okay, everyone? Can we move on to the next question? So I hope everybody is having the correct answer, that is Leaford 2 fracture line. If you have got any doubt or you're not understanding it, please let me know. Because what I want that everybody should revise the question being asked, and you should know about the elaborate discussion of all the things which will be asked from this topic. So that means these topics are very, very important for 2024. So a quick revision and is required. So yes, so is it okay, Dr. Nitika, Dr. Shruti, Dr. Sandeep Mahata, Dr. Saini, Dr. Pranav, Dr. Afrin, Dr. Sandeep, Dr. Devinder Singh? So let's move on to the next question, that is question number 12. Okay, so let's move on to the next. So which of the following layers of the epithelium compromises the stratum germinatum layer? Is forming the is forming the stratum germinatum layer. So all of you please mark the right answer here. All of you please mark the right answer. So this is again a question of histology being asked. It can be also included in the pathology question, but I have included it as a histology question being asked in the anatomy session. So which of the following layers of the epithelium is compromising, and it is consist of stratum germinatum? The layers are stratum basale and parabasal layer, stratum corneum and stratum granulosum layer, stratum granulosum and stratum spinosum layer, stratum lucidium and stratum basal layer. So we have got 4 options and you have to choose the right answer. So Dr. Nikita, Dr. Sandeep Mahata, both of you are giving A as the answer. What about others? Okay, so we have got 4 options and you have to pick the most right answer. So again, I got an answer only for Sandeep, Mahata and Nitika. So actually the correct answer is stratum basal and parabasal layer. So both of you are correct. A thumbs up goes for you. Both of you are correct. Actually, when I am talking about stratum basal, so yes, Shayad, you are also right. Dr. Shayad is also right. Stratum basal. So when I'm talking about stratum basal, the other name which can be used for stratum basal is stratum germinatum. It is stratum germinatum, and it is the deepest layer of the epidermis which is separated from the dermis by basement membrane. So it is resting over the basal lamina. That means it is resting over the basal lamina. Devender Singh is telling first option was not there in the exam. Okay, okay. So let me okay. Okay, let's see. Okay, so exactly if I talk about the stratum basal, the other name of stratum basal is stratum germinatum. So those who remember, if anybody remembers the option, they can write in the messages so that I can exactly those who have, all of you must have given the NEET MDS examination. So if you are remembering the question and along with the option, please write it. If any corrections I have to make, I will correct it. It was stratum basal. Okay, similar thing only. Stratum basal and germinatum is similar thing attached to the basement membrane by hemidesmosome. So here what happens? This is the stratum basal layer, which is also called as stratum germinatum, connected to the dermis by hemidesmosomes. Okay, it is connected to the basement membrane by hemidesmosome. Now from inside to outside, the layers are stratum basal, stratum spinosum is there. Then we have got stratum granulosum and lucidium, and the most superficial layer of the epidermis. If I am talking about the most superficial layer of the epidermis, it is stratum corneum. So as you proceed from inside to outside, so if I just want to want everybody to note down the layers as you proceed from inside to outside. So I'm just concentrating on the epidermis part, not the dermis part. We are starting with the stratum germinatum, stratum basal, which is connected to the dermis via hemidesmosome, stratum spinosum, and stratum lucidum, stratum corneum. So I go, okay, Dr. Shayad is telling that stratum granulosum was there. Okay. So, okay, I also think I got an update from one of the student only that stratum basal was there. Okay. So he is telling that. Okay, okay, it's okay. Stratum basal and parabasal layer is there, then it is good. Now, if I talk about stratum basal or basal layer, together they are termed as germinatum layer, and it is the deepest layer of all the 5 layers of epidermis. So it is the we know that what is epidermis? It is the layer which is covering the skin in case of the mammals. The stratum basal is a single layer of columnar or cuboidal basal cells. And if I talk about this layer, it is connected to each other. It is connected to the next layer, that is stratum spinosum, and also via hemidesmosome and desmosomes. Now, the nucleus. The characteristic feature of this layer is that the nucleus is large and ovoid, and it is located in the most of the part of the cells, some of the basal cells. If I talk about stratum basal or germinatum, why it is called as germinatum? Because it is acting as a stem cell, and it has the ability to divide and produce new cells. So ultimately, it is also sometimes have the keratinocyte stem cells are there. So that is its ability. The basal cell layer is the innermost layer or the deepest layer of epidermis. It contains small rounded cells. They are called as the basal cells. So what lies in the germinatum layer? Basal cell. It has the ability to form other layers, so what it is called as germinatum layer. The basal cell continuously divides and the new cells are constantly piling up. Okay, so constantly pushes the older one towards the surface of the skin, and eventually they are shed off. The basal layer is also termed as stratum germinatum due to the fact that it is constantly germinating and producing the new forms of the cell. So the layer which is contained in the germinatum is the basal layer, and having the ability to form newer cells, so only the term germinatum is given to this layer. The basal cell is called a germinatum layer due to the fact that it has got the ability of producing new cells. So this is very, very important, and it should be noted by everyone. This was a question which I have included in anatomy, but this is a question which can be also asked in the pathology part. Okay, so yes, Nitika, Dr. Nitika and Dr. Shayyad is telling the options were like this one. Okay, squamous cell layer. The squamous cell layer, if I talk about, it is also called as the stratum spinosum. So the next layer is stratum spinosum, and squamous cell is the layer which name is given to the stratum spinosum. It is spiny layer, which is due to the fact that the cells of this layer is connected to each other by a spiny projection. They are connected to each other by a spiny projection. Keratinocytes produce keratin, a tough protective layer of the protein that make up the majority of the structures in the skin, hair, and the nails. If I talk about the next layer, it is the stratum granulosum and stratum lucidium. The keratinocytes form the squamous layer, and then they are pushed towards the epidermic layer, and they lead to the formation of stratum granulosum and stratum lucidium. So you can study the stratum granulosum and stratum lucidium together. So exactly, if I talk about these cells, they are bigger, flatter, and they are more adherent to each other. And they basically, after some time, they dehydrate and they can die. So if we start from inner to outside, we have got the stratum basal germinatum layer. Then we have got the spiny layer, and then we have got the stratum granulosum and that of lucidium. After that, I would also like to talk about the most superficial layer, that is stratum corneum, which is the outermost layer of the epidermis, and it is made of 10 to 30 thin layers, which is constantly shedding, and dead cells are going keratinocytes. The stratum corneum is also called as horny layer. Why it is called as horny layer? Because the cells are tough like an animal horn. If I talk about the outermost layer, which is also providing protection to the inner layers, they are termed as a horny layers. They are termed as horny layers. So exactly, here also we have seen all the layers, and we are knowing that just adjacent to dermis is the stratum basal layer, which is the right answer. And we have also talked about the features of these layers being seen in the histological image. So I grabbed these questions being asked just the exam which was taken for the MDS dental examination. I wish everybody best of luck. Before ending, I would like to tell you about few facts, and then we can go to end the session. Before ending, I would like to tell you a few facts about the DBMCI platform. So there is an advanced plus course. Don't settle down for the lows. Okay. So don't settle for any less, and go for the advanced course, dear. Pre-bookings are available now. Pre-recorded videos are there. 600 and plus hours of high quality pre-recorded lectures for all 19 subjects. So go for it. Extensive question banks are there. So we have got 20,000 question banks, exam relevant, high yield, and well structured questions, which will help you to crack the examination of MDS. So go through this with a better explanation. And many of the clinical questions and image based questions has been added on. So this will be highly beneficial if you want a quick revision and you want to crack the exam with a better score. Now, other than that, I would also like to tell you, don't settle, don't stop. Competitive test series are there with 19 subject wise, one image based, 12 GTs are there, and multiple mock and mini tests are there. So go through, attempt all these GTs, all these grand tests, all these multiple mock tests and mini tests, which will help you to get a better rank in your competitive exam. So clinical world. So I would also, so the basic and the most important point is the clinical world, which is the clinical work added in the MDS group. 40 more hours of clinical videos are there with special focus on the doctor patient interaction, which will be highly beneficial for you. So all of you, yes, Sandeep Mata, thank you so much. So I would like everybody to assess this clinical world. This will be highly beneficial for you. So hard copy notes are there. That is very important for you. And exactly, it is carefully crafted, high quality, time stamped notes for all of the 19 subject, which will be very useful for you. So that is highly important here. And if I talk about the revision videos, so if I talk about the revision, all the 19 subject revision videos are there. So more than 160 hours of revision videos are there. So you go through this, this will be highly beneficial for you. So daily mentorship is given by Dr. Himani Joshi to help you to stay motivated and being on the track. Advanced Plus, don't settle for less. Advanced Plus, get a subscription. Use the code MOLAR and get the subscription at a lower rate. Okay. And I also want you to tell that get your doubts clear right itself on the DBMCI MDS group of the Face group and Telegram group. Don't settle, don't stop. All the best and keep studying. So yes, thank you so much, Dr. Nitika, Dr. Sandeep, and everyone. If you have got any doubt, otherwise I will end the session. If you have got any doubt, please let me know. Otherwise, I will end the session. All the best and keep studying. Thank you so much. We'll meet for the next session. I hope everyone is going to get a better rank in this examination because all the questions were asked directly from the notes and this will be highly beneficial. So go through all these MCQs and which other subject MCQs has already been discussed. I think anatomy was slightly late. So I'm sorry for it. Okay, okay, Dr. Shruti, okay, Dr. Nitika Bora and Dr. Sandeep Bora, Dr. Syed, Dr. Shruti, so everyone, Afreen, Dr. Afreen, Dr. Devinder Singh, Nit. Thank you. All the best. Keep studying. Thank you so much.